First, let's understand the basic difference between a leukemia and a lymphoma. In a layman term, if you want to understand, leukemia would stand for a blood cancer and lymphoma will stand for a lymph node cancer. So that's how you explain it to your non-medico friends, and that basically means that till the time the cancer cells, I'll draw these as the cancer cells, till the time these cancer cells are roaming around in the blood, you will call it a leukemia. One fine day, these cancer cells say that I want to go and sit inside a lymph node. Imagine, I'm going to denote cancer cells with red color. One day, these cancer cells say that I want to go and sit in the lymph node over here. Can I say that the leukemia has changed into a lymphoma? Can I say that? Yes. So basically, it's about the site. See, both of them are cancers, but when would you call it a leukemia? When it's inside the blood. And the same thing goes into a lymph node, I call it a lymphoma. Same way, guys, can I also say that from here, for example, there was a cancer over here, the blue color cells. Initially, patient had lymphoma. One fine day, those lymphoma cells say that I want to go and sit in the blood. Can I say lymphoma has changed into a leukemia? So in simple words, what I wanted to explain to you is that leukemias will change into lymphomas, lymphomas will change into leukemias, and all of that is interchangeable. So your terminology depends on the site. Leukemia is when the cancer is in the blood, lymphoma is when the cancer is in the lymph node. First, I'm going to start with leukemias. And what is the basic classification of leukemia that all of you know? Leukemia can be of two types, that is acute and chronic. First, let me tell you all the terminologies. Then I'll tell you what is the clinical aspect, what is the blast count. So first and foremost, acute leukemias are known as ALL as well as AML. And chronic leukemias are also referred to as CLL and CML. These are the four things that you're going to study for the next part of this segment. So when I talk about ALL, ALL stands for acute lymphoblastic leukemia. See, the name will tell you a lot about it. Acute lymphoblastic leukemia. Whereas CLL is chronic lymphocytic leukemia. Now look at this thing, because most of the students make a mistake over here. ALL had what? Acute what? It had acute lymphoblastic, because here you have lymphoblasts. Whereas chronic is known as chronic lymphocytic, because here you don't have blasts, here you have lymphocytes. And that is the basic difference between acute versus chronic. Acute is going to have a lot of blasts. For that matter, whenever the blast count is more than 20%, we call it acute leukemia. And whenever the blast count, we say less than 20%, but honestly telling you, when the blast count is almost negligible, that is when you call it a chronic leukemia. So what is the basic difference between acute versus chronic? Acute is going to have a blast count of more than equal to or more than 20%. So that is why when you wanted to call it ALL, acute, if it's acute, it's going to have blasts, right? Lots of blasts. So what do you want to call? You call it lymphoblastic. But when you go into the chronic variety, chronic doesn't have any blasts. That means I won't call it blastic, I will call it chronic lymphocytic leukemia. You've got the basic in place. Now let's look at AML and CML, because here I'm calling it as AML is acute myeloid leukemia. Acute myeloid leukemia, and CML is going to be chronic myeloid leukemia. CML is chronic myeloid leukemia. But now I do notice some discrepancy here. Like for lymphoid variety, I was clear cut saying that is blastic, this is cytic, lymphoblastic, lymphocytic. But for myeloid, I've not used the word myeloblast, I've not used the word myelocyte, I've kept it simple. Acute myeloid leukemia, chronic myeloid leukemia. What is the reason? Because go back to the first slide of this chapter. Did I tell you that lymphoid progenitor just takes care of lymphocytes, lymphoblasts, and then sleeps off? Everything else needs to be taken care of by the myeloid progenitor. So when I say myeloid leukemia, acute myeloid leukemia is just not myeloblast. It will have monoblasts also. It will have red blood cell blasts also. It will have the megakaryoblasts also, because myeloid had to make everything. That is the reason that myeloid leukemia, it's acute. Definitely blasts are there, but all kind of blasts can be there. And in chronic myeloid leukemia, the blast count will be very, very less. We'll elaborate on those, but to give you a brief hang as of now, what I'll start with is ALL, which is acute lymphoblastic leukemia. By now, you guys know a lot of things. Let me ask you your knowledge. What do you understand by acute? What is the blast count? More than 20%. What do you understand by lymphoblast? This also you guys know. You guys know what is a lymphoblast. In a lymphoblast, you've already studied what is the special stain. Tell me, are you going to see an odd rod? No, you will not see an odd rod. What is the special stain? Past positivity, block positivity that you studied. And what was the special stain for a T lymphoblast? It was acid phosphatase. That much of information you already have. Now is the time to apply that information. So let's start with acute leukemia. And in the acute leukemia, the first thing is that you need to know blast. So guys, acute, only acute leukemia. Can you tell me what is the blast count? So for all practical purposes, acute leukemia has a blast count of more than 20%. However, this is what WHO has said. There is another group, WHO everyone knows, World Health Organization, but there's another group called FAB, French, American and British. You don't have to know the full form. I'm just telling you people from all these origins, French, American and British, they have said that more than 30% blasts is the cutoff. So then you'll ask me, what should I follow in the exam? Follow what WHO has mentioned. More than 20% blasts is the criteria for acute leukemia. Where are these blasts present? That is the next point. So they could be present either in the bone marrow or and in the peripheral blood. So many students come back to me with this query that more than 20% blasts where? So number one, either it is in the bone marrow or it is in the peripheral blood, or it is in both. So I have to just document more than 20% blasts in any one location, because on the basis of that, I will now tell you a definition of what is known as aleukemic leukemia. So what a weird kind of a thing. See, leukemia is there. Leukemia is there means the blast count is definitely more than 20%, but that blast count is more than 20% only in the bone marrow. When you did a simple blood test, of the person, when you picked up the peripheral blood, you realized that there were no blasts seen. So imagine, I do a simple blood test of a person and I say, no, there are no blasts, but he has all the symptoms. I'm saying, but no, I've taken 5 ml of his blood. I'm trying to look at blasts. I'm not finding any blast, no lymphoblast, no myeloblast, no monoblast, no kind of blast is there. But when I look at his bone marrow is studded with lots and lots of blasts. That tells me it is definitely a leukemia, but it is not coming out in the blood. It is when I call it an aleukemic leukemia. But it is a leukemia. Why? Because at least the bone marrow shows you, na? So that is what I'm trying to tell you. At least one location should be showing you, either bone marrow or along with the blood. Any one place should be showing you, or even both can show you more than 20% blast. That is what is an acute leukemia. And which acute leukemia am I starting with first? I'm starting with ALL, as you said, acute lymphoblastic leukemia, which is the most common in children. ALL is very commonly, or the most common leukemia that you see in children. This is also the most commonly seen leukemia in people with Down syndrome. Remember, I had taught you this in genetics also, that Down syndrome overall means no age mentioned. They've not mentioned 2-year-old, 10-year-old or 20-year-old person with Downs. They've just said a person with Downs and which blood cancer is he at a risk of. So remember, overall the risk of is ALL. Overall it is ALL. And it is the most common in children. Now let's start with the classification. Please remember that when we go ahead with the classification of ALL, again there are two bodies. One is the French, American and British body, and the other is the World Health Organization body. So let's start with FAB, French, American, British categorization says there is something known as ALL-L1, then there is something called ALL-L2, and something called ALL-L3. But tell me, whichever kind of ALL may be there, which blast am I talking about? We are talking about lymphoblast, and what is the cutoff? It should be more than 20%. So please remember, ALL-L1, if I just look at all these blasts, I can zoom in also if you want. Do you see they are all of the same size? Pick up one size and roughly with a minor variation, but roughly all of them are of the same size. Can I say the same kind of blast is seen everywhere? Can I say L1 shows you one population? L1 shows you homogeneous blasts. L1 is going to show you homogeneous blasts, one population. When I talk about L2, now try to look at it. L2, can you see some of them are a little smaller, some of them are medium, and yes, I can see a variation. Some are small, some are huge, chota bada, that is what you can see. So I can see 2 cell populations. I can see heterogeneous blasts. I can see heterogeneous blasts that are noted. So I have learnt it in such a simple way. ALL L1 will show me one type of blast. All of them are of the same size. And ALL L2 is going to show me two type of blast, that is heterogeneous. When I talk about ALL L3, guys, this is the most different looking, the most variant looking, because if you look at it very carefully, the blasts are showing you certain white holes. Can everyone see those white holes in the blast? Those are cytoplasmic vacuolations. Why are white areas coming? ALL L3 blasts are showing me vacuolations because these vacuolations contain fat. Now all of you are going to tell me, if it contains fat, I have a stain which everyone is aware of, and that stain is oil red O positive. So they ask you a simple question. Out of ALL L1, L2, L3, which of them is oil red O positive? ALL L3 is oil red O positive. Now, further they will ask you, which of these is the most common and which of these is the least common? So L1 is the most common, L3 is the least common. Which of them has the best prognosis? So the most common one is going to have the best prognosis or excellent prognosis, whereas the least common one that you have, that is L3, that is going to have the worst prognosis. This is what you have to learn. Quick repeat. When I go from L1, L2, L3, my simple concept, L1 has one type of blast. All of them are small, same size. L2 are two types. Some are small, some are big. Then small, then big. So two type of blasts. L3 is having oil red O positivity, so it has fat. L1 is most common and good. L3 is least common and bad. The update over here is that they are saying that ALL L3, and listen to me very, very carefully, they are saying that ALL L3 is very similar to a lymphoma. And what lymphoma is it? That lymphoma is known as the Burkitt's lymphoma. It is very, very similar to Burkitt's lymphoma. So that's an update. So now that means that in the later part of this chapter, when I'll teach you Burkitt's lymphoma, the same cells I will be showing you, because if I keep the same picture, I say these cells are seen in a leukemia, you will say ALL L3, but I say these cells are seen in a lymphoma, and you're gonna say Burkitt's lymphoma. So these are the three type of blasts that you have over here. But is there any variation sometimes that you see? Something very beautiful. Sometimes you see cells which are hand mirror looking. Hand mirror shaped cells. Can you see the cytoplasm is coming out? It's looking like a beautiful hand mirror. So hand mirror cells are also a variation that you see of the lymphoblasts, a variation of the lymphoblasts. So by chance, if the examiner is saying there is a leukemia, 20% blasts are there, blasts are showing hand mirror morphology. Hand mirror means look at the mirror matlab lymphoblasts are going to be hand mirror in shape. What was this, guys? This was the FAB classification. I have another organization, World Health Organization. What has World Health Organization says? WHO never goes for 1, 2, 3 numbers. World Health Organization says either it's going to be a BALL origin or it's going to be a TALL origin. So firstly, remember this is going to be seen in children, and TALL, T for teens. So remember, TALL is going to be seen in teenagers. That will be your first hint in the paper. BALL in bachas, that is how we learn it. BALL in bachas, children, and TALL in teenagers. After that, which of them will go into the tissues? So TALL is going to show me tissue infiltration. What do I mean by tissue infiltration? So what tissues? One at the top of the body, one in the middle of the body, one at the bottom of the body. That is how we learn. Top, middle, bottom. So in the top, we say it can go into the brain. Second, in the middle of the body, you will say mediastinum. It can come as a mediastinal mass. So mediastinum, and at the bottom, especially in males, it is going to result in testicular involvement. So they ask you a very simple question. There is an ALL, it is showing you brain involvement, or it is showing you testicular involvement, or it's showing you mediastinal involvement. Which ALL are you thinking? Which goes into the tissues? The T goes into the tissues. So simple, TALL in teenagers going into the tissues. Very, very good. And now you are left with the genetics. So which is the one which shows you notch mutation? So again, notch has a T. So notch mutation is going to show you TALL. Means what are the genetics that you have for BALL? BALL is going to be, BALL is associated with PAX5 mutation, E2A and EBF. How do I learn this? Out of all of these, what you have to learn is going to be PAX5. Why? Because now I'm telling you a rule for a lifetime. PAX5 gene God has given us. All of us, God has given us a PAX5 gene. You know why did God give us? To take care of our B cells. To take care of our B cells, God has given us PAX5 gene. So for B cell development, simple, I'm repeating once again, God has given you PAX5 gene for your B cell development, which means that if your PAX5 is lost, loss of function, if your PAX5 is lost, will your B cells develop? No, they will not develop, which means what? Which means lymphoblast, will it develop into a lymphocyte? No. Lymphoblast will remain lymphoblast, and that is why lymphoblastic leukemia is occurring. If PAX5 would have been good to go, lymphoblast would have made a lymphocyte and I would have been normal. But here PAX5 is not there. If PAX5 is not there, only and only lymphoblast, lymphocyte, lymphoblast will be seen. I hope that's okay with everyone. So simple. Whenever the B cell word comes, PAX5 has to come. That's the rule made by God. And what is for T leukemias? For T leukemias, it is the notch mutation. That's the difference of what BALL and TALL. Now put your logic into it. Which of them is sounding to have a better or a worse prognosis? So my common sense tells me that something that is going into the brain and the testes and the mediastinum and so many organs can never ever be good. It is having the worst prognosis. So I'll put a very, very sad emoticon in front of this. This is going to have a poor prognosis, of course. Whereas BALL is Badhiya. So this is going to be Badhiya and in Bachchas. Badhiya and in Bachchas means it's going to have a good prognosis and it's going to occur in children. Badhiya in the Bachchas. Whereas TALL going into the tissues in the teenagers with the notch mutation, the TTT, has a poor prognosis. Now, having said that, let's also talk about the genetics. I'm going to make a long list. Suddenly you'll want to shut off the video when you see that list. But then I will also tell you one way of learning that list which will make you switch on the video once again. What is the genetics of ALL? So first let me make you switch off the video, and I don't mean it literally. Continue. There is something known as hyperdiploidy. Then obviously the opposite of hyperdiploidy becomes hypodiploidy. So ALL can show you both. ALL can show you hyperdiploidy also and hypodiploidy also. Then ALL can show you trisomies. Trisomy chromosome 4, trisomy 7, trisomy 10. ALL can also show you translocation 1221. ALL can also show you translocation 922. ALL can also show you a problem in the MLL1 gene. Now, how do I learn this? What is the entire concept going to be over here? So first and foremost, some of them are good and some of them are bad. That is how I've divided it. So all these that I've written over here, these are going to have a good prognosis. So now what is the methodology of learning is that ALL has 3 alphabets. So now I've told you the bad part. Now I'll restore your faith in my lecture that okay, if I've given a list, I will give you a way of learning it. So ALL, 3 alphabets. Now, so anything with the number 3 is going to be good. Anything, rule of 3. So let me ask you. Tell me what is diploid? Diploid is 2n. All of us are diploid, 46 chromosomes, 2n. More than 2n means hyperdiploid. More than 2 is anyway 3. So is that going to have a good prognosis? Yes. Anything in 3s are going to be good. Trisomy. Trisomy means 3 copies. Is trisomy going to be good? Yes. And trisomy of which chromosomes? Trisomy of chromosome 4. And after that add 3s. 4 plus 3, 7. So trisomy 7. Add another 3. 7 plus 3, 10. So trisomy 4, 4 plus 3, 7, 7 plus 3, 10. So these trisomies, all threes, they are good. Translocation 1 to 2, 1. 1 plus 2, 3. 2 plus 1, also 3. Another 3 thing coming up, so it's good. See guys, now do you have that faith that you will be able to solve questions? Anything 3, 3, 3 in ALL is good. And everything else now that you have becomes the bad prognosis. These are going to be the bad people. These are going to be the bad people. So now tell me, hypodiploidy. This is not coming out to be 3. 922, not at all 3. MLL gene, nothing to do with 3. So all these become bad prognosis. So simple. The rule of 3 says all the 3 things are going to be the good things. But which out of these is the most common genetic alteration? Hyperdiploidy is the most common genetic alteration that you see. I want to stop over here because many of you by now must be a little confused about 922, because 922 was seen in that Philadelphia, the CML. I'll be coming to that. 922 can be seen in a lot of places, and there's a very important question. And here we go. What is 922? When I say there is a translocation of 9 and 22, in simple words, there is a fusion of a protein called BCR and ABL, and this results in the formation of a Philadelphia chromosome. This much of information, if you're not aware of it, you will be studying it shortly under CML, because I am saying that this is primarily for CML, but right now I'm saying translocation 922 is for ALL also. So how do I know what am I talking about in the exam? Has examiner asked me ALL wala or CML wala? For that matter, there is another leukemia called chronic neutrophilic leukemia. So ALL full form everyone knows, CML full form you know. Now I'm telling you the full form of CNL, very controversial entity. There is something known as chronic neutrophilic leukemia. You know, BCR-ABL fusion can be seen in all. Translocation 922 can be seen in all of them. So how will I know? You go in 20. I've written them in an alphabetical order if you have noticed. A alphabet comes first, so ALL. Then we have CML and then CNL. For that matter, you can also learn it as LMN. LMN is alphabetical, na? So ALL, then we have CML, and then we have CNL. LMN, you write it in an alphabetical order, and now after that, you are going to put 20, 20, 20 ke difference mein weight. If the BCR-ABL fusion protein weighs 190 kilodalton, it is ALL. Plus 20 karo, 210 kilodalton CML, plus 20, 230 kilodalton CNL. Simple. So first in the exam, you will write LMN. So ALL, CML, CNL, 190, 210, 230. And you know the bad part is that lesser the weight, as you are decreasing the weight, you know what is happening? When BCR and ABL fuse, actually what happens? Tyrosine kinase activity increases. So lesser will be the weight, more will be the tyrosine kinase activity. Lesser will be the weight, more will be the tyrosine kinase activity, means worse is going, more activity means worse tumor. So tell me, which has the least weight? The least weight is in ALL. So this means ALL is going to have maximum tyrosine kinase activity. So does that make BCR-ABL good for ALL or bad? It makes it bad for ALL, and that is what you had written over here. Translocation 922, Philadelphia chromosome, the BCR-ABL 190 kilodalton is going to have a bad prognosis, because lesser the weight, more is going to be the tyrosine kinase activity. That was the logic. But coming back to your ratta part, after the logic, we also need mnemonics. So all the 3, 3 and 3 things in ALL are going to be good. Having said all of that, we now need to discuss the clinical features. So somewhere the age is almost clear to everyone. This is very commonly seen in children. Now tell me something. It is an acute lymphoblastic leukemia. Which cell is prominent? Lymphoblast. Means that lymphoblast is going to proliferate so much that in the bone marrow, everything else is going to be suppressed. So let us now do something. Let us sit over here and try and make a bone marrow, because that will tell me so much about it. So for example, although this hardly looks like a human bone, it's looking more like a dog bone. But yeah, for our space, we've drawn it like that. When I talk about ALL and I say that there are lots and lots of lymphoblasts, so I will write lymphoblast, lymphoblast, lymphoblast everywhere. Everywhere there are only lymphoblasts present. So what about the other cells? With the excessive proliferation of blasts, there is actually a suppression of the other lineages. You can see so many lymphoblasts are proliferating in the marrow. So what is going to happen to the red blood cell lineage? It is going to get diminished, as a result of which my patient is going to suffer from features of anemia. There will be fatigue, tiredness, pallor. So all of those features of anemia would be one of the presenting complaints that the patient will have. After that, only lymphoblasts are increasing. What about the rest of the cells? What about the neutrophils and the monocytes and the eosinophils and the basophils? All those others have decreased, right? These are the cells which fight my infections. Now, there is no one to fight my infections in this patient, as a result of which the patient lands up with what? Repeated infections or recurrent infections. That's another complaint that would come across. What else? What is the third lineage? The platelet. Of course, the platelet count is also suppressed because it's like a full dominance of blasts only. Everything else has been suppressed. Now, if the platelets are not there, for obvious reasons, your patient is going to land up with bleeding manifestations. So this is how you analyze a case of ALL. A patient, a child, so obviously it's more common in children. A child coming to you with anemia, fatigue, pallor, with recurrent infections, with bleeding manifestations, and then along with that, sometimes there might be organ involvement. There can be hepatosplenomegaly. What if there is a TALL? Do we all know that TALL tends to go to the tissues? So that might result in what? It might result in involvement of the brain or the mediastinum, or in males it can be testicular involvement. All of these have been noted, and that is what you see in the clinical features of ALL. So now when that patient comes to you, how are you going to do the diagnosis? The first thing that you do is a peripheral smear or peripheral blood. And on peripheral blood, what should be the blast count? If it's an acute leukemia, be it the peripheral blood or the bone marrow, the blast count should be more than 20%. And guys, what else? Which blast am I talking about? We are obviously talking about the lymphoblast. So now all of you are going to tell me that what are the different stains of a lymphoblast. Have we already studied this? That number one, lymphoblasts are pass positive and they show you the very, very famous dot, blot or the block positivity. Yes. Other than that, have we also studied that there is one stain particularly for the TALL? And what was that stain? It was the acid phosphatase. So that's why I said if you've done the beginning of this chapter, your life is going to be very, very easy. You won't have to run around learning these individually. This is all of it that you have, that you know. And finally, if you have to go ahead, know the CD markers. If you want to know the CD markers because you want to know whether it is a BALL, the B cell markers are there or the T cell markers are there. Obviously, for the CD markers, you are going to go ahead and do flow cytometry. So that has nowadays become the diagnosis of choice. The diagnosis of choice has become flow cytometry because that tells you all the CD markers. Right towards the end of the leukemias and lymphomas, we are going to study flow cytometry. And for every leukemia, lymphoma, we are going to do these markers as well. Okay, having said that, now the last part of it that you need to know is about the prognostic factors, most of which you know, trust me. See, the age which is said to be good is a 2 to 10-year-old and usually a female. Now, this means someone less than 1-year-old or someone above 10-year-old and the male gender is bad. Now, why is the male gender considered bad? Any reason for that? Because did I tell you that there is going to be an involvement of brain is male, female both, mediastinum male, female both, but testicular is going to be males. So because of that testicular involvement, please remember there is going to be bad prognosis in males. Now also remember the blacks, in terms of race, the blacks are said to have a bad prognosis. In FAB classification, this you already know. Remember, L1 was most common and good, L3 was least common and bad. Similarly, in WHO classification, the BALL was badhiya in bachchas, BALL was badhiya in bachchas, whereas TALL, which was going into tissues was very, very bad. Finally, the genetics, I think you already know all the 3 number things were good. Means what were the good ones? Hyperdiploidy. What were the good ones? Hyperdiploidy was said to be good. Then all the trisomies, what trisomies did I teach you? Trisomy 4 plus 3, 7 plus 3, 10. Trisomy 4, 7, 10 was good. And also I hope you remember translocation 1, 2, 2, 1. That is also good. So basically all the 3-letter things were good, whereas things like hypodiploidy, translocation 9, 22, MLL gene, all of these come under the bad prognostic variety. So as a result, you realize if you've done the beginning of ALL well, the prognostic table is done. Whether it is FAB, whether it is WHO or genetics, you've studied it. Same holds for the gender also. The only extra thing that you have to study is the age. A 2 to 10-year-old female child is best. That's how I've learned it. 2 to 10-year-old female child is good. Everything else is bad. And in terms of race, for the blacks, it is said to be bad prognosis. On that note, let's get ready with some questions. The first question that we have is, oil red O positivity is seen with which of the following? ALL, L1, L2, L3 or all of the above? I told you that be ready for this question coming up your way. Oil red O positivity means which were the blasts which were showing you vacuolations? They were ALL, L3. And did I also tell you that ALL, L3 is now said to be a counterpart of one lymphoma also? And that is the Burkitt's lymphoma. Let's move on to the next question. There's a 14-year-old boy, so I have a teenage boy, number 1. Next, there's chest discomfort. So there's chest discomfort, you want to look at the lungs first. There's normal bilateral lung field. Lungs are normal on chest X-ray. But on CT scan, there is a mediastinal widening and an 11 centimeter mass in the mediastinum noted. So there's a teenage and there is mediastinal involvement, means there is tissue involvement, and biopsy from the mediastinal mass shows cells of lymphoid lineage which are positive for TDT, CD2, CD7. What did I teach you about the T cell markers? Did I say CD 1 to 8 and 28? This is what I made you learn, 1 to 8 and 28. See, 2, 7, all TDT and all these T cell markers are coming positive. I know for a fact, further, molecular studies show notch mutation, another T cell thing coming. See, everything is going in beautifully in favor of TALL, whether it is the T for teenage or it is the T for tissue or it is the T cell markers or it is the T for notch mutation. All of them are going ahead with TALL. The last question that we have, definitely a lengthy one, but super simple for all of you. Let's read. You have a small kid, a 5-year-old boy with a 1-month history of loss of appetite, fatigability, unexplained irritability, and intermittent low-grade fever. The patient's mother says he also often has bone pain, especially in his lower limbs. Physical examination shows generalized pallor, splenomegaly, lymphadenopathy, and because he had lower bone pain, lower limbs, so there's tender to palpation also. However, there is no joint swelling, warmth, or erythema. Lab investigations, hemoglobin of the child is low. See, everything, obviously you know it, there's a bias, it's a case of ALL because that's all that you've read. So now you know all the other parameters will go down. His hemoglobin has gone down, the white blood cell count is good, but the platelet count has again gone down. Platelet count is also decreased, that is 90,000. Peripheral smear shows the presence of atypical lymphocytes, and bone marrow shows 30% of the bone marrow as a homogeneous population of lymphoblasts. If it is more than equal to 20% lymphoblasts, I am calling it ALL, and that the examiner has told me also. More the examiner speaks in a question, more information he lets out to you, which means that it's better to get lengthy questions. You might be very scared of them, but see, in that event of speaking more, he's given you the diagnosis. Which of the following chromosomal abnormalities is associated with an unfavorable prognosis? If I'm dealing with ALL, I know 3-letter things were good. So what about the trisomy? That's good. This trisomy also good. Hyperdiploidy, more than 2 is 3. That is also good. Translocation 922 is associated with an unfavorable prognosis. Remember the BCR-ABL, and do you remember the BCR-ABL fusion? The weight in BCR-ABL fusion was how much? It was 190 kilodalton for ALL. On that note, we finished off our discussion of ALL, that is acute lymphoblastic leukemia. We now move on to the other one, and that is AML, acute myeloid leukemia, with the same concepts that you already know till now. You know that it's an acute leukemia, so for obvious reasons, the blast count is going to be equal to more than 20%. But now the twist in the story is what blast? Because myeloid is like, an umbrella term. It's going to include a lot of things under it. So now let's go into a little bit more details. So yes, when I talk about AML, again, there are two types of classifications. One is the French, American, British, and the other one is the World Health Organization. If you know French, American, British classification, which is the lengthier one over here, half of your job for WHO classification is done. So that is exactly what I'm starting with. AML, French, American, British classification ranges from AML M0 all the way up till AML M7. So let's begin on this rather long journey. When I talk about AML M0, you have to understand that the name of this is AML undifferentiated. It is AML undifferentiated. So now I'm going to tell you a lot of names. So you have to get used to learning these names. So how do you learn this? Undifferentiated sounds like anda. So remember, anda is 0, right? So AML M0 is undifferentiated. You know why do we call it anda or undifferentiated? Because I had told you a while ago that all the myeloid lineage cells are myeloperoxidase positive. Did we not study this? That all the myeloid lineage cells are supposed to be myeloperoxidase positive. But when I'm saying anda, that basically means that over here myeloperoxidase shall be negative. That is the question that you get on AML M0. Let's move forward and talk about AML M1 versus AML M2, because what is their terminology known as? This is known as AML without maturation. This is AML without maturation. And the next one is going to be AML with maturation. So how did I learn these two? Obviously, the story of the younger brother and the older brother. The younger brother is M1, the older brother is M2, bigger number, bigger elder brother. So younger brother is never ever, the younger sibling is never ever going to be mature, very childish. So younger sibling does not have any maturity. The older sibling, of course, is a very mature person. So younger brother immature, older brother mature. So M1 is without maturation, M2 is going to be with maturation. And let me tell you, M2 is the most common AML that you have. The maturity is the most common, okay? And it shows you translocation 821, which is a fusion of proteins called RUNX1, RUNX1T1. RUNX1T1 fusion is what you see. So please repeat once again, because you're talking about the story of the brothers, M1 versus M2 brother story you're talking about. M1 was the younger brother without any maturity. M2 was the older brother with maturity. Maturity is more common because you're talking about brothers. The genetics also that I've put up over here is something sounding like brothers only. RUNX1, RUNX1T1, same names are there. And that is translocation 821. Right at the end, I will give you a hint of how to learn these as well. This is about AML M2. Let's move forward, guys. I hope 0, 1, 2 is clear. The anda story along with the two brothers story, because now I'm going to go on to AML M3. First, you need to know the other name. AML M3 is known as APML, acute promyelocytic leukemia. It is going to be acute promyelocytic leukemia. That is what we understand by APML. So now, for obvious reasons, you will first ask me the genetics. The genetics over here is translocation 1517, and 1517 is the fusion of PML and RARA. PML and RARA. I want to elaborate a little bit on PML and RARA because PML sounds a little heard of. Promyelocytic leukemia, PML, is promyelocytic leukemia, whereas what is RARA? RARA stands for retinoic acid receptor alpha. Retinoic acid receptor alpha. So in other words, retinoic acid, it's a receptor for vitamin A. I want to tell you the pathogenesis. You know, this pathogenesis and treatment is very different from the other leukemias. That's why examiners love asking you this question. So listen to me carefully. Do you all remember that pathway that we had drawn for myelopoiesis? Do you all remember that the first cell in the lineage is a myeloblast? After a myeloblast, the next comes the pro-member, that's the promyelocyte. After that, I'm going to write short form so that, because after this, the rest of the story we're not much interested in. We have myelocyte, we have metamyelocyte, then we have a band form, and then let's assume that this made a neutrophil. Everyone remembers this story, right? So blast, promyelocyte, myelocyte, metamyelocyte, band form, and a neutrophil. Whenever someone has this translocation of 1517 or PML rara, you know what it does? It comes and creates a block over here. There is a block that is created over here. This means that when there is a block present, will any cell mature? No. Which is the cell that will keep on increasing? Lots and lots of promyelocytes will be there. Therefore, what is the name that you've kept for it? It is acute promyelocytic leukemia. Now, let me draw these promyelocytes. These promyelocytes are going to be, they are cancer cells. Na? They are cancer cells at the end of the day. So, how are they going to look like? They are going to look a little deadly. Means what? For example, if this is a promyelocyte and this is the nucleus inside it, you will see that it has a lot of rods. It has just like OR rods, yes, but those are not simple rods. Those are crisscross OR rods. Those are lots and lots of OR rods. We call them crisscross OR rods, and that is known as a faggot cell. That is known as a faggot cell. Have a look at this picture. Can you see the same thing over here? There is crisscrossing of OR rods that is noted here, that is noted here, that is noted here. These are all referred to as faggot cells. They ask you this question. Faggot cells are seen in AML M3. Now, the purpose of me telling you this is that these faggot cells and these OR rods have a property. Now, all these faggot cells that we are talking about, these faggot cells and these OR rods, they contain something known as a procoagulant material. They contain procoagulant material, which basically means that if this by chance comes out of the cell, it's going to cause clotting in the body. A lot of clots are going to happen. It's going to result in DIC. So which is the only leukemia? That is a question that they are very fond of. Which is the only leukemia which can cause DIC, or which is the only leukemia associated with DIC, disseminated intravascular coagulation, and that is going to be this AML M3. Very, very, very important question for your exam. So now on the same note, you've understood the logic. So now I want to ask you on the same note, what do you think is going to be the treatment of AML M3? What is the treatment of AML M3? So you'll say, why are you asking me only the treatment for this? Why not all the other leukemias? All the other leukemias are chemotherapy. But here, we do not give chemotherapy. There is no chemotherapy. Why? Because as far as I know, chemotherapy means kill the cell. If I kill the cell, all that procoagulant material will come out and my patient will land in DIC. If I end up killing this cell like this, all this procoagulant material will come out and my patient will end up having DIC, lot of clots. So I can't afford to kill this cell. No. I can't kill it. But I know that over here I had made a block. By chance, if I remove this block, somehow if I can remove this block, for example, if I can remove this block like this, the cell will nicely go into a myelocyte, metamyelocyte, neutrophil, properly mature, and this patient will not have any problem. The main problem is of this block. How should I remove this block? Why was this block occurring? This block was a genetic problem, retinoic acid receptor alpha problem. Retinoic acid, vitamin A ka problem tha. Correct the vitamin A and everything will be fine. So the treatment that I give in this case is going to be ATRA, all trans retinoic acid. The problem was in vitamin A, correct that vitamin A receptor. All trans retinoic acid is what we give, and along with that we give arsenic trioxide. Along with that we give arsenic trioxide. So it is very, very essential to look out for two things. When you're dealing with AML M3, number one, you have to see this classification and you have to see the genetics. Translocation 1517, PML rara, you have to see. Second, you have to see the picture of these faggot cells. Very, very important. And thirdly, you have to focus on the treatment. You won't give patient chemotherapy. If you give patient chemotherapy, he will die of DIC. You will give the patient ATRA and arsenic trioxide, which also means that over here the genetics was so important, isn't it? So if they ever ask you what is the diagnosis of choice, what is the diagnosis of choice for AML M3, you will always say that it is fish. Why? Because over here I have to, I mean it's mandatory, I have to look at the chromosomal translocation 1517. That wraps up AML M3 for me. I am going to go forward and talk about AML M4, M5, M6 and M7. So let's write them down. Here we have AML M4. and I've taken it along with AML M5. What is common in between them? Now comes the story. This is known as acute myelomonocytic leukemia. Myelomonocytic leukemia. Do you see a new member coming up? Yes, I can see a new member, that is mono, not only myeloblast, now monoblasts are also there. So basically, I realize that AML M4 is going to have myeloblast also, point number 1. And it's going to have monoblast also. Myeloblast as well as monoblasts will be there. Whereas when I come to AML M5 is known as, cut out the myelo, only mono. AML M5 is known as acute monoblastic leukemia. So no points for guessing which is the only blast that it has. It only and only has monoblasts. So repeating once again, AML M4. I really like this because I'm going to do a little bit of mathematics over here. And that mathematics says that AML M4 shows you an inversion. That inversion is known as inversion 16. That inversion is known as inversion 16. So how have I learnt it? I have learnt it. 2 square 4 square 16. I've done mathematics over here. What is the two things are 2 kind of blasts. It is going to show you 2 type of blast, myeloblast also, monoblast also. So when you see 2 type of blast, do 2 ka square, what is it? 4. So which AML will you think of? You will think of AML M4. And if you do 4 ka square, what do you get? 16. So 4 4s are 16. That is how we learn it. 2 type of blasts. You do a square, you get AML M4. AML M4, you do a square, you get inversion 16. When so much of mathematics you have done, remember mathematics was your core subject starting from your first, second class right up till your 12th. Even in physics, mathematics was your core subject. Wherever you have done your mathematics means now the genes that you learn will be core binding factor with MYH for maths. It's sounding like maths, something to do with maths. MYH and CBF is what? It is core binding factor. So remember, core binding factor along with MYH is what is the fusion. So it's a simple way of learning. Because you were doing 2 square 4 square 16, you were doing a lot of maths. I did core binding factor with MYH as the fusion. Now this is all about AML M4 where there were 2 type of blasts. Then I came to AML M5 where there is only and only monoblast. But do you know the problem with these mono? As soon as the word mono comes into the story, these are the ones responsible for tissue infiltration. These are the ones responsible for tissue infiltration. And tissue infiltration means it's going to go into the gums. The patient is going to come to you with gum hypertrophy. The patient will come to you with gum hypertrophy. It can go into the skin. Imagine leukemia going into the skin. What do you call it? You call it leukemia cutis. Leukemia cutis is leukemia going into the skin. So I realized that this mono is the one that goes into the tissues. Wherever mono comes, that is AML, M4 and M5 go into the tissues. Repeat. What in ALL was going into the tissues? The TALL was going into the tissues. In AML, M4 and M5 go into the tissues because monos go into the tissues. Coming to the next, the last two, AML, M6, which is referred to as, now see, from the beginning I've been telling you, it's not just myeloblast. Myeloblast you have seen, promyelocytes also you have seen, monoblasts also you have seen. Now you're left with RBC blasts and platelet blasts. I'm going to show you those. This AML M6 is going to show you an erythroblast, pure erythroid leukemia. It is known as pure erythroid leukemia. For that matter, it is given another name, that is Guglielmo. So it's a funny name, of course, but yes, this is the name of the disease, that is AML M6. Guglielmo disease is AML M6. Okay, so now I've learnt it as a googly over. I've learnt it as a googly over, and over has 6 balls, है ना? तो googly over है, that is the Guglielmo. So googly over is going to be the cricket related basically. So 6 balls in an over and googly. That is how we learn. Finally, coming to AML M7. First, I'm only left with what? The platelet blasts. What are the platelet blasts? Megakaryoblast, acute megakaryoblast leukemia, acute megakaryoblast leukemia. This actually is the least common, Okay, but where is it more common? But it is most common if you have a Down's baby of less than 3 years. See, most common only if you have a Down's baby syndrome situation. Otherwise, it's the least common leukemia in the AML series otherwise. And this is the leukemia which tends to give you a dry tap. What do I understand by a dry tap? I have told you this concept way back in your beginning of hematology in the RBCs, even before that. Dry tap means that bone marrow aspirate did not give you any solution or did not give you any yield. You tried to aspirate some material out from the bone marrow and nothing came out. Why? Because there was fibrosis in the marrow. There was fibrosis in the marrow. So repeating once again, because now we are going to make a final table for all the different AML. So first I'm going to give you a list and then we are going to discuss the further situation. So let's start from AML M0. When I say M0, 0 for unda means nothing, undifferentiated. Even myeloperoxidase will be negative, total 0. M1 and M2 was the story of the two brothers. The M1 younger brother without maturation, M2 older brother with maturation. Matured one was common, and the name of the brothers were only coming rungs 1T1, that is translocation 821. Now we come to AML M3, the one which was most deadly, because this is the only leukemia which is associated with DICY, because it shows you lots and lots of faggot cells, and all those cells contain a lot of procoagulant material. Why did they happen? Because there was a translocation 15-17, PML RARA. RARA means there was a vitamin A problem. So how are you going to treat them? You're going to treat them with vitamin A and arsenic trioxide. What was M4 and M5? 4 and 5, finally your story of mono starts. 4 was that mathematics. 2 blast, myeloblast, monoblast. So 2 square AML M4, 4 square, that is 16, inversion 16. And when you did so much of maths, core binding factor with MYH was the fusion. AML M5 was only and only monoblast, but as soon as the mono word comes in 4 and 5, that means that is going to show you tissue infiltration, gum hypertrophy, skin involvement is going to occur. M6, 6 balls in an over and googly in cricket. So Guglielmo's disease is what you call it. So googly in a cricket and 6 balls in an over. That is a pure erythroid leukemia. 7 is the least common, the least spoken about, unless I have a baby of Downs who's less than 3 years of age, then it becomes the most common. It is acute megakaryoblastic leukemia. So all said and done, I want to sort out one thing which is regarding Downs, and there's always a lot of confusion. Which is the most common hematological abnormality of Downs? Most common hematological abnormality seen in Down syndrome? Which is the most common leukemia that is seen in Down syndrome? And which is the most common leukemia that you see if the baby is less than 3 years of age? Baby is less than 3 years. See, these 3 questions are different. As soon as I say hemat problem, everyone starts answering leukemia because you're always focusing only on leukemias. No, leukemias happen in Down syndrome, that is right. But that's not the most common hematological abnormality. The most common hematological abnormality is TAM, transient abnormal myelopoiesis. Transient abnormal myelopoiesis, which means the name is only telling you everything. Will there be some abnormal cells? Yes, abnormal cells are formed, but they are for a very short duration. They are for a very short duration, that is going to be transient. TAM, that is the most common hematological abnormality. So within 6 or 7 months, everything comes back to normal. So if you see bad looking cells in a Downs baby, don't straight away put it up as leukemia. Maybe it was being produced for 6 to 7 months and things will be back after a while. But if they categorically ask you which is the most common leukemia and they have not mentioned the age, means they are asking you overall. If they are asking you overall, it is ALL. But if they mention the age of less than 3 years, then it is AML M7. These are your 3 questions that you have to know. The most common hematological abnormality is transient abnormal myelopoiesis. Most common leukemia overall is ALL. And leukemia most common in less than 3 years of age is going to be AML M7. With that, we wrap up our entire AML fab classification, and trust me, the fab classification is so fab because once you studied it, the WHO classification becomes easy in a lot of ways. So now I'll tell you that WHO classification has 4 or 5 groups that I'm going to talk about. The first part of the WHO classification says that it is AML with recurrent genetic abnormalities, and I think half of those abnormalities you have done. Recurrent genetic abnormalities. So let's start. Did I ask you what was in AML M2? M2 was translocation 821. And do you remember the brothers which were fusing? Runx1, Runx1T1. Runx1, Runx1T1. Then what was in AML M3? In AML M3 it was translocation 1517. And what was the fusion happening? That vitamin A thing. PML RARA fusion was happening. What was in AML M4? In AML M4, you had that 2 square, 4 square, 2 square, 4 square, 16. So inversion 16 was happening in AML M4. And do you remember what was that mathematics? Core binding factor with MYH was what was fusing over there. Now, I'll tell you some more. These are the ones you knew, that because this was occurring in M2, this was occurring in M3, and this was occurring in M4. If you ever get confused in the paper, go by multiples. 16 will always come with 4. 15 will always come with 3. And 8 will always come with 2. So by chance, all these are written and you forgot that, okay, which one was for M2? So you will, or which one was for M3? You'll say, okay, 15 is going with M3. So 3 ka multiple is 15, right? So M3 is 15, 17. M2 must be 8, 21. And M4, obviously, 4 4s are 16. Other than that, there is something known as translocation 122. There is something known as translocation 69. And then you have certain AMLs which have other mutations. AML with NPM fusion or NPM mutation. AML with NPM mutation. Then there is an AML with CEBPA. There is an AML with CEBPA mutation. There is also an AML with MLL. The list goes on and on. But these are the main ones that you have to learn. So see, M2, M3, M4 you anyway remembered. Then I've given you the first and the last chromosome. The numbers, forget the sex chromosome, but the first and the last chromosome is translocated, that is 122. Then we have something called 69, again multiples, close numbers. AML with MPM, AML with CEBPA. Out of these, please remember, can there be an AML with lots and lots of eosinophils? And can there be an AML with lots and lots of basophils? These two scenarios they will ask you in the paper. Let's do a repeat. Can there be an AML with lots and lots of eosinophils? Yes, that is AML M4, means inversion 16. Inversion 16 means AML M4EO, that is how you call it. Whereas what is it with basophil? Translocation 69 will show you a lot of basophils. Repeating, please remember, when you're talking about AML M4 inversion 16, that can show you lots and lots of eosinophils. Whereas when you're talking about translocation 69, that is over here, you will see lots and lots of basophils in the story. That is something if you're targeting the higher institute exams. So these were all your recurrent genetic abnormalities. Now we move on to the other part. So what is the second part of the WHO classification? They say there can be AML which can be therapy associated. There can be AML which can be therapy associated. When I say therapy associated, it could either be something like alkylating agents, exposure many years ago to alkylating agents, to topoisomerase agents, topoisomerase inhibitor agents. So to all therapy related, therapy was given for some other disease and then later on person had AML. Next, AML following myelodysplasia or AML associated with MDS, that is myelodysplastic syndrome. Is there a criteria for it? Yes, AML associated with myelodysplastic syndrome tells me that in these patients or MDS patients, you should have at least more than 50% of the cells show myelodysplasia. 50% of the cells show myelodysplasia, and this should be there in 2 or more than 2 lineages. What lineages? 3 lineages are there, na? RBC, WBC, platelet. So at least 2 out of them should be involved. Out of RBC, WBC, platelet, at least 2 should be involved, and in them, more than 50% of the cells should show you myelodysplasia. What is dysplasia? Dysplasia is pre-malignant changes. Remember, dysplasia ka definition from general path, pre-cancer. So pre-cancerous will only result in cancer later on. Na? So in other words, if I ask you if AML is a cancer, what is the pre-cancer stage of AML? The pre-cancer stage of AML will be dysplasia, myelodysplasia. So myelodysplasia should be present in how many cells? More than 50% of cells. Of how many lineages? More than 2. 2 or more than 2. Okay, coming to the fourth category, that is said to be AML NOS, and you know what comes in AML NOS? It is very similar to the FAB, except AML M3 is not included. Means everything else has been copy pasted, M0, 1, 2, but not 3, not that PML RARA, because they said for AML M3 you need translocation 15, 17, which has been included over here. That is why they said you can't put it under NOS. Other than M3, from M0 to M7, everything comes under AML NOS. So WHO has done a little bit of stealing from FAB. Okay, now coming to the fifth and the last one is going to be AML with Down syndrome, which I think everyone knows now. Which AML is going to be associated with Down syndrome? It is AML M7, and that too Down's babies less than 3 years of age. So these are all your AMLs with their FAB classification and WHO classification, but there comes another point as to what is a chloroma. A very, very famous, a little bit of a controversial question. What do you understand by chloroma? Firstly, they called it OMA, but go back to your neoplasia chapter. I have told you that it is not a benign tumor. Chloroma is not a benign tumor. It is very much a malignant tumor, and it is known as what all? It is known as, other than chloroma, it is known as a granulocytic sarcoma. So yeah, sarcoma word is telling me that it is a cancer. Myeloblastoma, because it's ultimately a type of AML. Why myeloblastoma? Because ultimately it's a type of AML, but AML is a blood cancer. Na? Chloroma is not in the blood. This is occurring in the soft tissues. So what is chloroma? Chloroma is AML in the soft tissue, and the most common site that they've asked you over here is the orbit. So it occurs in the orbit. So the eye will be pushed forward. What is going to be the clinical feature? The clinical feature will be proptosis. So repeating once again, chloroma is nothing but a kind of a cancer. It's a blood cancer. It's an AML only, but that AML has not happened this time only in the blood. It has happened in soft tissue like orbit. So the eye will be put jutting forward. That is basically proptosis will be there. Now finally asking you, what will you see microscopically? Of course, it's an AML. I will see myeloblasts. There's no doubt about it. I will see lots and lots of myeloblasts, but other than that, I also see Arbiskov cells. I also see the presence of Arbiskov cells, and that's such a major misconception students have, that acha chloroma ya myeloblastoma hai to Arbiskov cells must be myeloblasts. No, Arbiskov cells are actually a kind of monocytes. They are atypical monocytes or macrophages. That is what is an Arbiskov cell. Please remember, Arbiskov cells are monocytes or macrophages. That is what you see in chloroma. So what is now coming to the marker? Chloroma ka markers, obviously if it's having myeloblasts, it has to be MPO positive. Other than that, remember, it is CD43, CD45 and lysozyme positive. Unfortunately, you will have to learn all of these. I wish I could escape these for you, but no. Question aata hai, you will have to learn. Repeating, it is going to be MPO positive because every myeloid lineage thing is MPO positive, 43, 45 and lysozyme. But now this what I've told you is very, very important. But now I'll tell you what is controversial. I told you it is AML of the soft tissue. Which AML is the next question? There are 2 AMLs that can occur. There are 2 AMLs that can occur, and now we will complete the story. That is AML M2 and AML M5. Actually, earlier it was said M2 is the most common. Now gradually literature is evolving, and they are saying M5 is also coming out equivalently important and even more commoner than M2. So there's a very close tie between M2 and M5. Remember, AML M2 and M5, both of them can result in that chloroma. On that note, you are ready for the diagnostic ability. Now, you know for a fact it's an acute myeloid leukemia. So, whatever blast, whether it is myeloblast, monoblast, erythroblast, or any kind of blast count minimum has to be more than 20%. So, for example, if I'm talking about a myeloblast, what was your identifying feature for a myeloblast? Identifying feature for a myeloblast was all rod. Yes. So, these have to be more than 20%. So, can I say that now there are a lot of CD markers that you will study. So, the diagnosis of choice for AML is going to be flow cytometry, because flow cytometry is the diagnosis of choice for everything hematological on this planet. Except, did I tell you that there is an AML, which is AML M3, which definitely requires translocation 15, 17 or PML RARA for its diagnosis. So for that, I will have to go ahead and look at FISH. So this is what I wanted to teach you, that for all the AMLs, the diagnosis of choice shall be flow cytometry. However, for AML M3, the diagnosis of choice is FISH, because I want to see chromosomes. I don't want to see CD markers. I want to see chromosomes. Chromosome which one? 15 and 17. Yes, this is one part. But now this is flow cytometry, FISH, little what? Expensive techniques. Can we have something which is more economical? And examiner loves these economical questions. The stain related questions. I've brought 4 stains in front of you. Let's see if you guys remember. PAS stain. Yes, PAS stain. Myeloperoxidase, chloroacetate esterase, non-specific esterase. Did you guys remember? Where all did you study? Where did you study myeloperoxidase? Myeloperoxidase was for which blast? It was for myeloblast. Same for chloroacetate esterase. Chloroacetate esterase was also for myeloblast, because non-specific esterase was for monoblast. Yaad aa raha hai? Non-specific esterase was for monoblast. What about PAS? Why have I written PAS here? PAS used to be for lymphoblasts. PAS was a case of what? PAS was a case of ALL. Why have I written it in AML? Because now note that even AML M3, M6 and M7 are PAS positive. So now let's start. First and foremost, what is AML M0? Why have I written it in almost disappearing font? Because it was ANDA. ANDA means that it is going to be MPO negative. Nothing positive in it, forget about it. Now out of these I have made you select that AML M3, M6 and M7, these are P for PAS, P for pink. They are PAS positivity that is going to be seen. Okay. In all the others, what do you see? In all the others, you see myeloblast. If you have myeloblast, this means you will clearly write that these are MPO and chloroacetate esterase positive. They are MPO and chloroacetate esterase positive. AML M4, M4 में तो सब type का blast होता है. They are MPO and chloroacetate esterase positive. But do you all remember that M4 and M5 also have those mono series? So is the monoblast non-specific esterase also going to be positive? So M4 also has non-specific esterase positive, and M5 also has non-specific esterase positive. Because wherever the monoblast will come, non-specific esterase will come. So now the question out of all of these is, quick revision, which of them doesn't show you anything under M0? Nothing. Which are the ones which are PAS positive? M3, M6 and M7 are PAS positive. Chuck them out. All the others will show you myeloblast. The myeloblast is MPO, chloroacetate esterase everywhere. But which two show you monoblast? Monoblast are M4 and M5. So M4 and M5 show you monoblast, that is NSC positive. So now my question comes, real question comes now. Which is the AML which shows dual esterase positive test? Which AML is going to show dual esterase positive? Dual, who will show both the esterases? Who will have both the blasts? Means myeloblast also, monoblast also. Which leukemia has both the blasts? Of course, it is going to be AML M4. AML M4 has both the blasts, so both the esterases will come positive. And that is the much expected question. AML M4 shows you dual esterase positivity. Well, now coming to the prognosis. Your prognosis is dependent on the translocations again. So can you tell me what was the translocation for AML M2, M3 and M4? So for AML M2, you had a multiple issue over there. We used to make multiples. So 2 ka multiple 8, translocation 8, 21. 3 ka multiple 15. So translocation 15, 17. 4 is 16. Inversion 16. So ultimately I realize all three these things that I have been mentioning, these are the ones which carry the good prognosis, whereas the others do not carry a good prognosis. These are the good prognostic features that you have for AML. Guys, lastly, you also need to know that AML has come up with some little updates and some little provisional categories. So first I'll tell you what is the provisional category. One of them you have to know. There is something called AML with mutated rungs, only rungs. AML with mutation in rungs 1, that is going to be a provisional category which will soon be included in the coming years into the main classification. That is an additional point. And now there's another additional point which is regarding the blast count. So for that I would want everyone to make a big table because it will help you a lot. Tell me something. For the diagnosis of AML, acute myeloid leukemia, what was the rule? That the blast count had to be equal to more than 20%. You could not break this rule whatsoever, but now I'm going to break the rule. If I see these three translocations above me, 821 or 1517 or inversion 16, if I see any of these are now good enough for the diagnosis of AML, then the blast count is not considered. Blast count is not considered. Means if I say, I'll give you a scenario, someone has an inversion 16 proven, inversion 16 proven, but the blast count is 8%. Basically 20% nahi hai, 8% hai. Will you consider it as AML? Yes, even if the blast count is not crossing 20, but this or this or this, any of these three, M2, M3, M4, any of these three have been documented, it is still an AML. That is very important, guys. Please make note of this. Whatever we've said, we need to practice the same with the help of questions. Otherwise, we won't be able to judge ourselves and our knowledge. So tell me something. Where do you see the highest concentration of OR rods? Where did you see that those OR rods were going crisscross like a faggot cell? So where was that faggot cell seen? In the very famous AML M3. And AML M3 was what? Acute promyelocytic leukemia. Everyone remembers the faggot cells going crisscross OR rods? Yes? Good. Practice one more question. Here we have a 15-year-old boy with history of bleeding gums. There is subconjunctival bleed and a purpuric rash. So first and foremost, a lot of students do this. They read bleeding gum. They're like, okay, which AML goes into bleeding gums and gum hypertrophy, M4 and M5. They start marking all this. Don't be in a hurry. Bleeding is not happening only from the gums. It is happening from the subconjunctival, skin, rash, purpuric rash. So many bleeds are happening. Then we went on to investigation. Obviously, the hemoglobin is low because he's bleeding. And the TLC is 26,500. So the TLC is elevated. Platelet count is 35,000. Platelet count is